Thank you for this invitation to talk about prediction models and confirmatory tests for giant cell arteritis. I have no financial disclosures, but will be discussing a potential $76 billion problem with you. Every ophthalmic technician who works with adults must know giant cell arteritis, or GCA, because A, GCA is one of the prime emergencies in ophthalmology and can cause blindness that is irreversible and not infrequently bilateral. However, GCA is preventable with glucocorticoid treatment if recognized in time. B, the projected cumulative economic burden of GCA in the United States by the year 2050 is estimated at $76 billion. C, medical legal claims for giant cell arteritis are settled by payment rather than defended twice as often as other ophthalmology claims, and the payout for GCA cases is 4 times the median cost of other OMIC claims. The objectives of this talk are to 1. Organize the symptoms, signs, and blood work for patients with suspected giant cell arteritis. 2. Estimate the pretest probability of giant cell arteritis with a risk calculator before confirmatory testing with either temporary biopsy, ultrasound, or MRI. And 3. Evaluate the pros and cons of temporary biopsy versus imaging for giant cell arteritis. On review, giant cell arteritis is the most common primary vasculitis in the elderly. Arterial occlusions from giant cell may result in irreversible blindness and occasionally diplopia, myocardial infarction, aortitis, stroke, or even death. In any patient 50 years or older who presents with vision loss, diplopia, headache, or scalp tenderness, giant cell arteritis must be considered. GCA is classified as a large vessel vasculitis that can affect the medium and small size vessels, notably the optic nerve and retinal circulation. The pathology of giant cell shows granulomatous inflammation in the arterial wall with activated macrophages that may be abnormally large and multinucleated, and as such, the appellation of giant cells. Giant cells are helpful in the pathologic diagnosis of GCA, but not essential. The immunology of giant cell arteritis is complex. Age-related deterioration in the arterial integrity and the immune system causes the normally quiescent dendritic cells in the vessel wall to become activated. The macrophage activation and release of pro-inflammatory cytokines drives T-cell polarization towards the T helper 17 and T helper 1 lineages. In particular, interleukin 6 increases the Th17 cells that cause the inflammatory symptoms associated with giant cell arteritis. T helper 1 cell proliferation causes an increase in interferon gamma with further macrophage activation, damage of the arterial wall, and vascular occlusion. There is a wide spectrum to the presentation of giant cell arteritis, from occult to isolated polymyalgia rheumatica, to fever of unknown origin, to large vessel vasculitis. Ophthalmologists are most familiar with the cranial variant of GCA, presenting with headaches, scalp tenderness, jaw muscle pain with chewing or jaw claudication, vision loss, and occasionally diplopia. A pale swollen disc or central retinal artery occlusion in an older patient are the classic findings for giant cell arteritis. Early and accurate identification of GCA may prevent the progression of vision loss, or at least vision loss in the contralateral eye. Although GCA is an important disease, it is uncommon and rarely seen in patients under the age of 50. The incidence of GCA varies by country, and in North America, clinically diagnosed GCA is seen in about 10 to 20 individuals per 100,000 population, 50 years of age or older. Giant cell arteritis is more commonly seen in women, likely because giant cell is a disease of immunosenescence, and women have greater longevity than men. The average age of patients with GCA in our series was 77 years of age. The diagnosis of GCA can be difficult, in part due to its wide spectrum of presentation, which can overlap with cancer, infection, and other diseases. GCA lacks a specific blood test. The erythrocyte sedimentation rate, or ESR, C-reactive protein, or CRP, and platelets are acute phase reactants that can rise in many types of inflammation and can even be normal in up to 4 to 10% of patients with giant cell. As a reminder, if you strongly suspect giant cell arteritis, the patient should be on 1 milligram per kilogram prednisone while awaiting test results. Higher intravenous doses are suggested in patients with vision loss. Now, due to the difficulty in the clinical diagnosis of GCA and the side effects of long-term glucocorticoids, including diabetes mellitus, hypertension, bone loss, peptic ulcer disease, glaucoma, cataracts, and psychiatric disturbance, temporal artery biopsy is traditionally performed to confirm the clinical diagnosis, although ultrasound may be gaining traction. Obtain temporal artery biopsy, ultrasound, or MRI within 1 to 2 weeks so that the glucocorticoid treatment does not confound your testing. As an aside, tocilizumab is an interleukin-6 inhibitor that may help decrease the dose of glucocorticoids and reduce the recurrences of giant cell arteritis. Note that the 1990 American College of Rheumatology pre-biopsy criteria for giant cell, that is age or ESR greater than 50, headache, and temporal artery abnormality, are classification criteria and were not intended for diagnosis. The ACR criteria misclassify many ophthalmic cases of GCA, in part because GCA can be occult, and infections, amyloidosis, cancer, and other collagen vascular diseases can mimic the presentation of giant cell arteritis. From this chart, you can appreciate the extensive history, physical, and testing that a patient with suspected giant cell arteritis requires, and as such, ophthalmic assistants are invaluable in patient triage. Some of you may be performing assessments of ocular blood flow in giant cell arteritis suspects using fluorescein angiography, ocular pulse amplitude, orbital color Doppler, or OCT angiography. However, these tests are adjuncts in the diagnosis of GCA. Either a temporal artery biopsy or imaging of the temporal vessels is usually still required to confirm the diagnosis. Patients have different pretest probabilities for giant cell arteritis depending on their age, symptoms, physical findings, and blood work. It is inappropriate to perform temporal artery biopsy on every patient with a headache, but difficult for doctors to accurately weight the multiple predictor variables that determine a patient's risk for disease. Studies have shown that properly formulated classification algorithms can outperform clinical intuition. To improve the diagnostic accuracy of GCA and decrease the number of temporal artery biopsies performed in low-risk patients, we formulated and investigated a prediction model for biopsy-proven GCA compliant with the Tripod Transparent Reporting Guidelines, and published this article in 2019. In addition to the ACR criteria, we employed gender, jaw claudication, vision loss, diplopia, C-reactive protein, and platelets as predictor variables. To improve statistical power, we maintained the age and bloodwork variables as continuous. From 14 predominantly North American medical centers, we retrospectively analyzed the data of 1,833 patients who underwent consecutive temporal artery biopsy. Complete case analysis of all 10 predictors was required for logistic regression and neural network classification models. and our final patient tally was 1,201 with 300 biopsy-proven cases of giant cell arteritis. On multivariable analysis, gender and diplopia were not statistically significant predictors for giant cell arteritis, which was confirmed on missing data analysis. Age, platelet level, jaw claudication, and vision loss were the strongest predictors for giant cell. Platelets, like ESR and CRP, are an acute phase reactant. Numerous studies have shown that thrombocytosis is a predictor for GCA. We found that the platelet level was a more reliable bloodwork predictor of GCA than ESR or CRP, with an average level of 372,000 per cubic millimeter in our biopsy-positive group. As such, if platelets cannot be maintained as a continuous variable, I suggest that the upper limit of normal for platelets in patients with suspected GCA be lowered to 370,000 per cubic millimeter. This is further supported by the fact that platelet count decreases with age. The receiver operating characteristic curve shows that our prediction model in purple handily outperforms the 1990 ACR criteria in red. Although prediction models are not infallible, the classification algorithm weights the risk contribution of the 10 predictor variables more reliably than human intuition, especially for the continuous variables shown by the yellow arrows, which behave in a non-linear fashion. Our prediction model is accompanied by a freely available online calculator which outputs an objective pretest probability for GCA, which helps clinicians and patients in shared decision making. The calculator can be used to estimate the pretest probability of giant cell arteritis for algorithms such as the British Society of Rheumatology guidelines, without reliance on clinical intuition, which is prone to bias. What happens if you still believe a patient has giant cell arteritis, but the biopsy or imaging returns negative? Using published data from meta-analysis on the sensitivity and specificity of temporal artery biopsy, ultrasound, and MRI for GCA, the post-test probability of GCA can be determined using a Bayesian analysis. Using this data may help you and your patient decide whether to perform a contralateral temporal artery biopsy or an alternative imaging test. Now let's review each of the confirmatory test options. There is controversy between the use of temporal artery biopsy as the reference standard versus imaging of the temporal arteries to confirm the diagnosis of GCA. The main imaging modalities are ultrasound, MRI, and positron emission tomography scan. In a 2019 survey, over 90% of ophthalmologists in North America prefer temporal artery biopsy to imaging as the confirmatory test for GCA. But in Europe, this may only be 75% of ophthalmologists. Rheumatologists in the United Kingdom and Europe prefer ultrasound in the diagnosis of GCA. I have no experience with PET-CT, but an apparent disadvantage of positron emission tomography is that it cannot distinguish between the increased uptake of GCA patients versus polymyalgia rheumatica. 3 Tesla gadolinium enhanced, fat saturated, multi-slice T1 weighted spin echo MRI of the temporal and scalp vessels perpendicular to the orientation of the vessels holds promise, and on meta-analysis has a sensitivity of 73%. 20% of patients with GCA may show some inflammation of the temporalis muscle. MRI with gadolinium is contraindicated in patients with severe renal failure. An MRA, that is MR angiography, 3D time of flight technique through the scalp arteries and circle of Willis with head coils may not require contrast. MRI of the orbits may show enhancement of the optic nerve or chiasm, but is not specific for the diagnosis of GCA. I now concentrate my discussion on temporal artery biopsy versus ultrasound of the temporal arteries. Temporal artery biopsy is the traditional reference standard for the diagnosis of GCA, but it is an invasive procedure, and it may require several days for the pathology result. Rubinstein's 2019 meta-analysis suggests the sensitivity of temporal artery biopsy is 77%, which is likely due to skip lesions. The specificity of temporal artery biopsy is considered to be 100%, and pathology allows identification of alternative diagnoses such as amyloidosis. Temporal artery biopsy may cost more than ultrasound and has potential but infrequent complications that include facial nerve palsy and rarely scalp necrosis or stroke. In about 1% of cases, the artery may be difficult to locate and a contralateral procedure is required. The diagnosis of GCA from temporal artery biopsy requires pathology expertise, and a fixed specimen of at least 1 centimeter is recommended. The symptomatic side should be biopsied to increase the yield. Doppler ultrasound of the temporal arteries for GCA has been reported for the last 40 years. Please note that when I refer to Doppler ultrasound of the temporal artery, it is not the same as orbital color Doppler, which qualitatively and quantitatively assesses retrobulbar blood flow. With Doppler ultrasound of the temporal artery, the main objective is to look for a thickened arterial wall due to edema, which appears as a non-compressible hypoechoic halo. For temporal artery ultrasound, a 15 to 18 megahertz linear array transducer focused 5 millimeters below the skin is recommended. The color Doppler frequency is 6 to 9 megahertz with gain to fill the lumen. The pulse repetition frequency is 2 to 2.5 kilohertz. Ultrasound has the advantage of being non-invasive, and on meta-analysis, the sensitivity varies from 68 to 77%. Ultrasound can examine the entire extent of the superficial temporal artery, other scalp vessels, as well as the axillary artery. In general, ultrasound studies cost less than biopsy at centers that have paid for the capital outlay of ultrasound equipment and staff training. Ultrasound can be performed serially to determine the response to medication. However, with ultrasound, there are at least 5% false positives. Atherosclerosis, amyloidosis, lymphoma, and infections can cause false positive ultrasound halos and result in inappropriate glucocorticoid use and toxicity. The European and British rheumatology societies suggest that at centers with sufficient ultrasound experience, ultrasound can be the first-line test for giant cell arteritis rather than biopsy. Please note that Schaefer's OMERACT study suggests that an experienced sonographer has performed more than 300 ultrasounds for giant cell arteritis. I review the meta-analyses of ultrasound from the rheumatologic literature that show that ultrasound may or may not be as sensitive as properly performed temporal artery biopsy. Renegel's group performed meta-analyses on largely the same articles as Duffner's group. When I asked Renegel why their sensitivity was lower, it was indicated that they contacted the authors of the ultrasound articles for missing information. I reiterate, there is a 5% false positive rate of ultrasound from disease processes that include atherosclerosis. There is also the risk of confirmation bias if the same clinician examines the patient and then performs the ultrasound. Temporal artery biopsy, in contrast, is thought to have 100% specificity. In my opinion, the side effects of unnecessary prolonged glucocorticoids from false positive ultrasound exceed any disadvantages of temporal artery biopsy. Individual clinicians must decide, given the gamut of diseases that mimic GCA, some of which are steroid responsive, whether a 5% false positive ultrasound rate is acceptable. The TABUL study comparing ultrasound and temporal artery biopsy is frequently cited in support of ultrasound for giant cell arteritis. Unfortunately, the abstract of the TABUL study does not mention that the performance of temporal artery biopsies was substandard in comparison with the excellent ultrasound studies. 7% of the TABUL temporal artery biopsy attempts did not even yield an artery. When an arterial specimen was obtained, 43% of the time it was less than the 1 centimeter minimum length suggested by the British Society of Rheumatology to avoid skip lesions. Please note, I am not against ultrasound or MRI and would be quite elated to never perform another temporal artery biopsy. You should use the test modality that your center has available and is most expert at, realizing that not infrequently you may have to combine pathology and imaging together. If you're planning to use ultrasound or MRI to diagnose GCA in the future, it would be prudent to correlate your first 50 imaging diagnosed GCA cases with pathology. The use of prediction models should provide higher yields from testing and perhaps reduce the number of temporal artery biopsies performed on low-risk subjects. To reiterate, your available local radiology, surgical, and pathology resources trumps the decision on which GCA confirmatory test you vote for. If you are not sure whether to go east or west, or if one test returns negative, you can combine test results if your index of suspicion for GCA remains high. You can't not just bide in your time though, as the sensitivity of all test modalities diminish with the duration of steroid treatment. It might be more swift to combine a tissue diagnosis with an imaging test rather than rely on 2 imaging tests. In summary, GCA is a vision-threatening and potentially life-threatening disease that every ophthalmic technician must be aware of. GCA is uncommon, but should be considered in the differential diagnosis in any patient 50 years or older with new onset headache, vision loss, or diplopia. Ophthalmic technicians can do much to help in the history, physical, and workup of patients with suspected GCA. Remember that in patients with suspected GCA, glucocorticoids should be started while awaiting the confirmatory test. Unfortunately, steroids have numerous side effects. Prediction models provide objective risk stratification to determine which patients might be able to avoid glucocorticoids or temporal artery biopsy. However, prediction models and bloodwork results are not infallible. We have discussed the relative pros and cons of each of the common confirmatory tests for GCA, including temporal artery biopsy, ultrasound, and MRI. Although temporal artery biopsy is an invasive procedure, it carries few complications and in North America seems to remain the reference standard to confirm the diagnosis of GCA. The future may show increased use of imaging. I appreciate the opportunity to connect with you. Hopefully this talk provides you with a good handle for the management of giant cell arteritis. I wish you health and happiness and that we can meet in person soon.